hello, everybody. Dr. Al Heuer here. I want to welcome you to this presentation, which really looks at the RTs and the RN, registered nurse role in special procedures in pulmonary medicine. So intubation, trachs, bronchs, and chest tubes. So some of the learning objectives that we're going to look at here will review our role that's common to many procedures. So kind of, I don't want to say irrespective, but there's certain things that you would do that are prudent and proper to do before you do most procedures, such as washing your hands, gathering your equipment, checking the physician's order to make sure it's there, checking certain laboratory results to make sure that in the case of like a bronchoscopy that I'll cover in a little bit, you want to look at coag studies, particularly if the physician intends on maybe taking some tissue samples. So a patient that has prolonged clotting times, it may be problematic for them to take a tissue sample. Bleeding may persist, things along those lines. So basically, we're really looking at different, again, roles and responsibilities that are common to many of the procedures that we do. We'll examine the procedure-specific functions, and again, more specifically, focusing on intubation, both performing the intubation and assisting with intubation. Tracheostomy tubes, bronchoscopy, and then we'll also look at chest tubes. So for the nurses that are in the audience, respiratory therapy has, in addition to our primary credentialing exams, we have secondary ones, or specialty ones. And one of the ones that we have is the adult critical care specialty. And I will tell you that they really emphasize all four of these procedures. So, it may sound like a little bit biased, but chest tubes are more common to physicians and nurses' scope of practice. But I know that our, if you will, credentialing body and accrediting bodies want us to understand them as well. Not just why they're done, but also the basic maintenance, troubleshooting of them as well. We'll also describe our role before, during, and immediately following these procedures, distinguish between or amongst the RT and the RN roles. In some cases, they overlap. Or the same. In other cases, they're separate and distinct. One of the examples I can give you is that, for instance, when we're facilitating a bronchoscopy and the patient is actually getting, let's say they're not mechanically ventilated, they're not in the ICU, they may be a patient that's going to the endoscopy suite, that's walking and otherwise talking, is that they, if we're giving them sedation, the sedation via IV should not be pushed by a respiratory therapist. It should be the doctor or the nurse that are actually pushing those medications. So in the case of handling what we call moderate sedation, and I'm not talking about the monitor, I'm talking about the actual administration of those medications. It's critically important that in most states, the respiratory therapist does not have in their licensure scope of practice the authority to do that, and it would really have to either be the nurse or the doctor. And then we'll be providing you guys with additional resources if you want to drill down and learn more about these topics. So the role that's common to many, I don't want to say all of these procedures, but many of these procedures before we're actually doing it, is know the applicable policies and procedures. And again, just know they may vary from site to site, but they should be evidence-based and they shouldn't actually vary, immensely. But knowing what the applicable policies and procedures are. If you follow your organization's policy and procedure, your current policy and procedure, for the most part, you're gonna, if something goes wrong, you're gonna probably be fine. Meaning, if there's something procedurally went wrong, whatever, but you follow the policy and procedure, to the T, it gives you a modicum of protection. More importantly, it helps ensure consistency. When you're assisting with a bronch or you're assisting or doing an intubation, it helps. If you will, number one, it's one of the definitions of a highly reliable organization where they actually do the same procedure from patient to patient very consistently. Okay. The second thing is also it's good for the patient. Not that it's consistent; it's safer for them. It's evidence-based. That if I do it, or if Terry does it, or someone else does it, it's good because we know that it's being done with a very, very small amount of if you will, variability, and a good amount of reliability, repeatability. Check for the physician, I say MD, but it could be a DO. So the physician's order, checking for things like informed consent, Certain emergent procedures such as intubation and other, trachs, artificial airways, the informed consent may be waived because it's a life-sustaining procedure. But there still needs to be documentation in the medical record to support that, informed consent wasn't obtained initially because it was emergent in nature. Assist in patient and family education, help screen the patient for contraindications, obtain baseline data. In one of my other presentations, I referred to, if a patient's heart rate is 120, but they're normally 98, their heart rates are normally 98, that increases, it's an increase, but it's not really notable. If their heart rate is 120, but they normally run at, let's say, 62, that's basically double their baseline. Okay, so obtaining baseline data is often very important as well. Gathering and preparing the equipment, if applicable, ensure a pre-procedure timeout. Also, if applicable, educating the patient on what's actually being done. So I referred to earlier on the ambulatory patient who's coming in for a bronchoscopy. It's very reasonable in the context of an informed consent to explain to the individual what's actually being done, why it's being done, what they can expect. Many times they'll be given, some xylocaine to numb the airway. You may actually have some lidocaine gel that you put into directly, numb the mucosa. The fact that the actual, if you will, tube that's actually put in the patient's, for spontaneous breathing, probably going through the nose. The tube that's going in is, about the diameter of a, small coaxial cable, things along those lines. It's the length of blah, 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 which is, and this is, many times we'll actually be, in your bronchus for, a short period of time. We may take some pictures, we may suction some samples out, and then, we'll take the device out. The most common complication, as you explain it to the patient, is just a little lowering of the blood oxygen. You don't have to use the term hypoxemia to them or whatever. It'd probably be inappropriate to do that, but that sort of a thing, and that would be treated with just increasing the FiO2 and the oxygen concentration. And in almost all cases, the patient responds very well, and so very few complications, whatever. But informing the patient, educating the patient on what's being done, why it's being done, any sort of major, if you will, potential complications, and the way that those are going to be resolved, and how you're going to find out the result. Who's going to communicate, how, what they found and or what wasn't found. During most special procedures, critically important. Patient safety is critically important, so we're monitoring the patient's vital signs. In some books, including one of mine, they talk about SpO2 as one of the vital signs, along with patient's temperature, their overall appearance, things along those lines. Responding to any adverse reactions, staying with the patient, monitor them. If they do require additional support, even like oxygen support, providing that to them as appropriate. Quickly obtaining help. So if you're in the room with the physician and the patient, there's something going on, a patient has an adverse reaction, let's say that the endoscope is actually touching the carina, and it elicits a significant decrease in heart rate, and whatever is calling an RRT, calling the appropriate, using the appropriate channels to get help, and communicating with others on the team. So it's responding to any adverse reaction. So the assist the physician with the actual procedure. When I say with medications, I mean, it's things like when we do a fair amount of Bronchs at the hospital I work at, a lot of them are actually, we've switched over to using disposable bronchoscopies. So we are in fact drawing things like mucus up in syringes, which in most states, respiratory therapists, that's not a problem in doing that, but it's the sedation that you just need to be careful with in most states. Again, needs to be done by the doctor or the nurse. And assembling all the equipment, getting it all set up. In many cases, the doctor wants to come in the room, they're going to do the procedure. They don't want to get hung up with setting up things along those lines. They want everything set up in advance. And in our case, depending upon which physician is doing the procedure, they have their own preferences as which side of the bed they're going to be on. So there's that sort of nuance as well, but you deal with that. After the special procedures, again, monitoring. Right? This is not a typo. So you're monitoring them before, during, and after, and you're documenting. Before the procedure, what their sats were, what the heart rate was, during the procedure, appropriate intervals, and after procedure. You process the equipment, document what you did, how the patient tolerated it, et cetera, et cetera. And if there's any, when I say charge, productivity, accounting for your productivity and a lot of these electronic health records, including Epic and Cerner, and there may actually be a direct charge. So, if you're doing if you're intubating the patient or you assist it with a bronchoscopy, there may be a charge for that where the hospital is actually getting reimbursed for that procedure. Intubations, let's start there. So this is kind of serendipitous because yesterday we actually had one of our competency days for our respiratory department, and this was my station, intubation, and we got some new equipment. So it was partly on intubation in general. Part of it was familiarity with, some of the glide scope system that we recently got, and we use video scopes, McGrath video scopes, so we're pretty familiar with those, but reviewing some of that as well. And then the old-fashioned, the good old intubation boxes with what you're seeing in this picture here. It looks like that laryngoscope is pretty much, it's probably stainless steel, and it's pretty much the traditional method that's available in most intubation boxes. Major indications to facilitate ventilation and oxygenation. If there's an acute airway obstruction, providing it's not so acute that the patient may better need a tracheostomy. Patient's apneic or hypoventilating, and it can't be reversed. So you get patients that maybe will hypoventilate who have too much narcotics on board that can be reversed with Narcan. So that's a judgment call that the physician team will typically make. Cardiopulmonary resuscitation, so you have a code blue situation. Again, intubation, the latest with ACLS is if you can get an advanced airway in, fine. But if you can ventilate the patient with either an LMA or just a bag valve mask, that's perfectly acceptable as well. And then intubating the patient during cardiopulmonary resuscitation, generally speaking, best to wait for a pulse check, because they're really not supposed to stop compressions, and it may present a bigger challenge to intubating the patient when the compressions are still going on. Contraindications, so presence of a valid, pardon me, DNI procedure, so do not resuscitate or do not intubate order, lack of properly trained personnel, lack of appropriate equipment. I was actually contacted by one of my cardiologist colleagues and said, hey, we want to, can you get me an endotracheal tube and a laryngoscope, whatever. And I'm like, it's much more than that. So we had this sidebar conversation where if that's what you want in an emergency, it's an outpatient, it's basically at a cardiologist's office, then it's, you really need to have an entire intubation box, including suction, including ambu bags, and entitled CO2 detector devices and things along those lines. So it's trained personnel. It's also the proper equipment. So who may benefit from an intubation? This is just showing you one of many X-rays. This patient looks like really is a diffuse pattern, possibly associated with ARDS, possibly ARDS with due to COVID, possibly. Some of the COVID X-rays looked a lot like this as well. Just kind of looking at the kind of more the upper airway, the neck region there, it is kind of interesting. It does look, whether this is a rotated image, it does look like the airway two things. It looks like it's a little bit skewed to one side, and it looks like it may actually be narrowed. That trachea may be narrowed as well. So it's one of the things that I actually, when I covered our intubation station for competency day, how do you judge a difficult intubation? So one of our roles with the physician is doing just that, is getting a Mallampati score if you have that luxury. Is actually if it's an elective intubation, looking at if you have the luxury of a chest X-ray that includes the neck. Many times it does. If there's any sort of notes from an anesthesiologist or a respiratory therapist that say it was a difficult intubation. If the patient can't be settled down, if the patient has come up, we give them medication, but maybe they have a high tolerance and they cannot be adequately medicated through sedation, they may need a rapid sequence intubation. They're sedated, they're paralyzed, the tube is then put in. So those are all things that we're involved with. Looking at the chest X-ray is part of that as well. Prior to intubation, identify potential need, screen for contraindications. Again, looking at the medical record to see if there's any indication that it's going to be a tough airway, looking at the patient themselves, adding that to the determination as well. Prepare and test the equipment, the laryngoscope, handle and blade, proper, multiple size ET tubes, pardon me, testing the cuff, a 10 ml syringe, just keep in mind that you have a 10 ml syringe. If you do end up using an LMA, and I know this is intubation, it's not putting in an LMA. Keep in mind that LMAs have about 3 to 4 times the volume. So if you're putting air in an LMA, you're deflating, you lube it up real good, you put it in place, it's going to take probably 30, 35, if you will, mLs of air in it versus 7 to 10 for an average, ET2, 5 to 10, 5 to 8, something along those lines. Just a little sidebar tidbit there. End-tidal detection device, so it may be colorimic where it changes color. The standard of care is we do a pretty fair amount of, respiratory does a pretty fair amount of intubations at the hospital where I work. We do a lot in either, the 2 units I'm most commonly in is medical and surgical ICU. We have waveform. So waveform capnography is the standard of care if you have it. It not only is useful in determining the tube is properly placed, but in a resuscitative effort, it also gives you a decent idea as to how the quality of the resuscitative effort, how good the compressions are, and if the patient returns to ROSC. So if they return to spontaneous cardiac activity, you'll pretty much see an abrupt increase in CO2 owing to the fact that now they're circulating blood around, and it's not through artificial means. The patient's heart is kicked in. Oxygen source, ambu bag, suction. And the oxygen source includes the flow meter, includes the delivery device, the ambu bag, etc. Patient preparation, hyperoxygenate, ventilate the patient, sniffing position, denture removal. The latest guidance is it's okay if it's not in your way. It is totally fine to leave the cannula, low flow, or the high flow nasal cannula on the patient if it does not interfere with your ability to visualize. It may buy you some time because now you're still delivering oxygen to the patient. It may well buy you some time. And then recommending meds. Different hospitals have different criteria for that. If it's a rapid sequence, it's not just going to be a sedative. It's also going to be a paralyzing agent such as succinylcholine. But things like recommending medications, we're able to intubate as long as we're not doing a rapid sequence. If we do a rapid sequence, the attending physician has to be there. And many times that'll be done by the attending physician or by anesthesia. But we're able to advise that the patient be given, let's say, 3 to 5 milligrams of Versed, up to 10. And sometimes what we're doing is we're actually doing fentanyl as well. And again, we can't push it, but we're recommending the doctors there, basically ready to help either administer those drugs or prescribe them so that nurse can administer the drugs. We've made our physician team has really made come to the realization that some of the patients that respiratory was intubating were not adequately, they were under medicated. So now there's this recognition that, we're kind of saying, jokingly, that you guys are cheating. You guys, you sedate them, you paralyze them. Of course, they're in easy intubation because they were flaccid. If we could at least, get them adequately sedated, we'd be able to, easily get it in as well. So there is some general recognition, in some sites that adequately, pre-medicating the patient is important. Different size tubes. So really, for most adults at 8.5, 9 is pretty much, they do go as high as 10. I've never intubated a patient with a 10 nor seen them with one, but certainly seen some 9s. Most commonly adults, 8, 8.5, small adult, female adult, 7.5. And then you can, kind of see where you graduate down from that. Laryngoscope sizes. So, large adult, 4.0, you guys can read like I can, 3.0, and it's really a matter of preference, whether you use a Miller, which is straight blade, or a Macintosh. And some of the blades are actually extreme, where you have like a CMAC, where it's really like almost a U-shaped blade. And that's like, some of it's driven by the airway, a lot of it's driven by the clinician, what they prefer. During the intubation, again, oxygenating the patient, ventilating the patient, or ensuring that's done. When we actually intubate, I don't really like to get too tied up in bagging the patient too long and tiring out your hands, and just, a distraction, but making sure that it's adequately done, assisting with it, etc. Assisting the physician with the equipment. So the physician's doing the actual intubation, the suction, various ET tube size, the syringe, the end-tidal device, monitoring the patient, any adverse, issues regarding elapsed time, things, a number of attempts, adverse reactions. the tube's in, but you're not getting either waveform, capnography, you're not getting color change, advising the team very promptly. That will happen invariably, but it's the matter of is identifying it quickly, because the patient, if it's in their esophagus, they're not getting ventilated, not getting oxygenated. The second related issue is if it is in the esophagus and you put enough air in anyone's belly, they're going to vomit. And then you have another complexity superimposed on top of it. Plate the cuff once the tube is in or thought to be in place, assess the placement. Initially, breath sounds are fine, but they're not all conclusive. End-tidal CO2. Esophageal detection devices are used. If you think about what's actually happening there, they look like they look almost like a bulb suction you use on babies, but you actually would connect it to the top of the tube. You squeeze it in, okay? If it reinflates, it's probably in the trachea. If it does not reinflate, it's probably in the esophagus. The esophagus is actually collapsing around it versus the trachea having the cartilaginous rings. Not a great, not a bad way to detect it, but they're becoming less in favor, these days. I will tell you things like fogging in the tube. There's papers published on this. I've had therapists over my shoulder saying, "Oh no, it's fogging. The tube is fogging up," and it was, whatever. But fogging the tube is typically not a good indicator. Certainly not conclusive. Again, immediately extubate if placement is in question. If the SATs are dropping, precipitously, if it was a blind intubation, if the belly's getting bigger, because you're listening over the lungs, you're also listening over the belly. So if you hear, gurgling sounds over the belly, no bueno. And monitoring your patient overall. After intubation, secure the tube, note the placement, reassess the patient. Things like suctioning as needed, ensuring that a chest x-ray is ordered. So you're making that recommendation, not actually ordering it. And then when the x-ray is taken, actually take a look if the tube is high, the tube is low. Things like, if the tube is in, you're getting end-tidal, but peak airway pressures are high, the tube's a little deep, give them a listen. And even before the x-ray, you may want to consider, it really sounds like, you got good breath sounds on the right-hand side, not much on the left. It's at, let's say, 26, 27, 28 mark. Consider withdrawing it a little bit, and as you're listening to the patient until you get good breath sounds. It may be, maybe the left lung is sicker than the right, but it could well be that the tube is just too deep. And then you find that they're easier to ventilate. Now you're getting good breath sounds on both sides. Secure the tube there, and then we recommend that the chest x-ray be got. Verify that the intubation order was written if the initial, was verbal. So it's not unusual. Emergently, yes, let's intubate the patient. But you want to make sure that you have that order, because for all kinds of reasons, it's the right thing to do. But if anything goes wrong, and then it's detected, a week ago, and this happened and that happened, well, there was no order for intubation. Oh, but it was verbal. And yeah, it's just not a good place to be. Take home notes on intubation. Ensure the patient is not a DNR, DNI. Beforehand, CPR, don't stop compressions for intubation. Again, easier said than done. For difficult intubations, consider other alternatives, LMAs. And just a word about LMAs, size-wise, biggest size they come in is a 5, 4, 3. So big adult 5 for someone. I'm about 5'9½". I weigh, I weigh about 80 kgs. So for someone like myself, probably around a 4 LMA. No light limitations. If you're trying to, even if you can't get the patient down, you can't get them sedated adequately or combative, et cetera, then, consider your options and consider calling anesthesia. If in doubt as to whether the ET tube is in the trachea, extubate and ventilate the patient and see. If you can, as I said before, if you can ventilate the patient adequately with a bag valve mask and can't intubate, it's not a terrible thing. It's not, they're oxygenating well, they're ventilating well. You don't have an advanced airway. It's fine for an interim period of time. Again, breath sounds may only be on the right, so you may be too deep, as I said a little earlier, and ensure that the chest x-ray is actually ordered. So let's look at tracheostomy here. At our hospital, we actually assist with, intubated patients. We assist in, if you will, transitioning patients over to a, to a trach tube. Patients that have been intubated, typically more than, 10 to 14 days. There are exceptions. If, we think that, the patient's been doing better, they're day 15, but they've been weaning a lot better on pressure support, we might give them a few extra days on that. But typically around 14 days. There's also some data out there to suggest that the longer you go out, particularly if you get out beyond 21 days with an endotracheal tube going through the vocal cords, there's more likelihood for vocal cord, if you will, a paralysis, vocal cord, some sort of damage of some sort. So it's traching patients is good because, some of them wean faster because it's a shorter tube. You could do mouth care, they can eat, better quality of life. It's not great, but better quality of life, but it's also the issues that I just mentioned. And tracheostomy can be done in the OR, also can be done at bedside. It's one of the most common special procedures done in the ICU. Technique is either open surgical, which is really going to be the emphasis here, but I wanted to, for the sake of completeness, wanted to also mention with a dilator kit. Can be done emergently in the ED or OR, or electively, at the OR or at the bedside. Indications, contraindications. So I alluded to a few of these. So emergent airway compromise. So things like trauma or epiglottitis, where patient has having issues, with just a swollen airway. It's really recommended that they perhaps not even attempt to intubate the patient, because you may lose the airway. The airway may be so swollen and so infected that they may actually just go right to a trach. Elective long-term ventilation, anatomical abnormality, obstructive sleep apnea. Yes, it's an extreme, if you will, way of addressing it. But obstructive sleep apnea is, if the patient has a trach, it's one of the ways that it's effective, but extreme. Contraindications, lack of informed consent, uncooperative patients, severe coagulopathy, untrained staff, inadequate equipment, and those sorts of things. So really looking a little bit at, what's what here. You're looking at, kind of ET tube replaced with a tracheostomy tube. So you can kind of see, one image here. You're actually looking at the carina. A lot of the x-rays today are all in digitized systems, your electronic health record systems. It's not only convenient, but it also gives you the opportunity to directly measure how far the ET tube is above the carina. So that's just kind of a sidebar conversation, but this is showing you, patient with ET tube versus patient with a tracheostomy tube. Open surgical versus percutaneous dilation method. Open surgical, the surgical opening is established between the second and the third tracheal ring, much more common than the dilation method. Again, percutaneous dilation, I'm just, again, discussing for the sake of completeness, where a guide wire is placed, through an anterior tracheal wall, followed by progressive stoma dilation. Okay. Both appear relatively equal in terms of safety and efficacy. It's been studied and generally has a very low, but not non-existent, but a low, procedure, complication and mortality. Our role beforehand, if elective, help identify the need, check the chart for the informed consent, the doctor's order, as well as contraindications, gather and set up the equipment. Also, it makes a lot of sense to have one size smaller tube, just in case there's difficulty in getting it in. You got a smaller size that you can get in there. That's, by the way, what you should also do once the tracheostomy tube is in place. Good idea to have one size smaller available. Syringe, a 10 ml syringe, scissors, trach connector, mechanically ventilated. We do a fair amount of assisting with these in the ICU, and it's once you're at the head of the bed, you're kind of trapped there. So it's a good idea to have, you have your scissors, you have your tracheostomy securing, device, your twill tape, or, your commercial device, et cetera, your ambu bag handy, your 10 ml syringe, and even things like the connector and your suction. If it's a mechanically ventilated patient, the suction, if it's an inline suction catheter, ET tube is longer, even have the shorter one that's available. So you can just kind of do everything at one time. Position the patient and yourself, appropriately at the head of the bed, wherever, so that you're out of the way of the physician that's actually doing it. Airway access without breaking sterile field. So again, getting to where you need to be, but not breaking that sterility. Prepare the existing airway, loosen the trach tie. So have it ready to, have the means by which the current and the tracheal tube is in place. Get it ready to go. Don't lose it. Don't lose it. Don't make it totally insecure. But at the same time, what you don't want is the physician will ask you to gradually let some air out of the cuff and retract the tube like 1 centimeter at a time. Okay. it's okay to be delayed a moment or whatever, but if you're still fiddling around with that, they're gonna stare at you and be like, have you done this before? Did you stay at a Holiday Inn Express last night? Like, what's the deal? So really be thinking ahead what's actually involved in assisting with it and be as ready as possible. And, obviously monitoring your patient. During your monitoring, so monitor, excessive bleeding, you're doing things like your saturation, your vital signs, preparing to remove the ET tube. So we're getting loosening the holder, connect the syringe to the pilot balloon, take care in doing that. You don't want to deflate it all the way, but, and again, you're prepared to take the air out of it. On the order of physician, briefly take patient off the ventilator. So that's common, so you don't have spray, particularly with COVID. It doesn't mean these patients, we did trach eventually a lot of COVID patients, but today we're taking precautions that we otherwise didn't take. So when I'm assisting with a tracheostomy or when I'm extubating a patient, okay, I will disconnect them from the ventilator. I'm talking about at the ventilator, so that when I'm disconnecting them at the distal end, so I disconnect the proximal, that's the vent outlet, okay, just as I'm ready to extubate them, or just as I'm ready to facilitate the removal of the tube so that the trach tube can be put in place. That way you're not spraying secretions at the distal end, okay? Yes, we have an N95 on, we have eye protection, et cetera, et cetera. The less secretions, the fewer secretions that you're aerosolizing in general is a good thing. In the advent of COVID, it's even more important. Gradually remove the air from the existing airway cuff on the direction of the physician, and gradually retracting the existing ET tube on the direction of the physician. Removing it on their direction as well. Connect the patient to the vent as ordered. So now you're connecting them to the vent on both the proximal and the distal end, vent outlet, as well as the distal end, the suction catheter and the Omniflex, and connecting, and then confirming that in fact that your peak airway pressures are not excessive, that you got end-tidal CO2, that you got bilateral breath sounds, et cetera. During COVID, I was assisting in a bedside a tracheostomy that was an effing nightmare. And it was a false track, and I was removing the tube. We were inserting, so he said, remove the tube all the way. He was inserting the tube, the new one, and it found a false track. And suffice to say that we were peak airway pressure, and the patient's SATs went down precipitously. We're not getting end-tidal. The only way we were able to ventilate them is when I retracted the trach tube almost all the way. So in other words, it wasn't quite out, but it was out of the false track. And we could then get end-tidal back. We could then ventilate the patient. Long story short, the patient's airway was so swollen probably from their COVID infection that, because we later reintubated the patient with a bronchoscope with a 7.0, and their airway, the patency of their airway looked like a crescent moon. And I remember that the physician was taking, he put it right to that. He's like held off, and I just kind of took it with his hand, and we just advanced it right through what we could. And, it was just it was one of those things. I know that, you guys, all or many of you were, have and continue to be involved in, treating COVID patients in some manner. So you guys probably have your own stories as well. But this was a physician who does a lot. He does most of our bedside trachs in the hospital I work at. It was just an unfortunate occurrence. Patient lived, but it was just hour and a half in the same room. It was a kind of hair raising, or one of the reasons why I don't have much hair left on my head. Our role for elective open surgical procedure. So after it, returning the patient to the original vent settings, monitoring the patient for adverse response, excessive bleeding, tube dislodgement, subcutaneous emphysema, addressing any adverse reactions. They may have some transient hypoxemia, suctioning the trach tube. They may have some blood and secretions, not unusual. I have a little bit of that, recommending a chest x-ray and documenting. And then again, if your system is to charge and to account for your productivity, doing that as well. That's part of the documentation. Take home notes for tracheostomy tubes and assisting with the placement. Make sure you have the correct tube size, one size down. Watch for the fire hazard from layering of oxygen beneath the sterile drapes. One of the ironies is you're typically putting the patient on 100% oxygen. At some points, you are 100% oxygen, that you are letting air out of the cuff, okay, of the endotracheal tube, meaning that 100% oxygen is now emanating from the patient's airway in some manner, okay? At the same time, the physicians many times are using electric cauteries, okay? So they have an ignition source. So it's not common It has happened. If you go in the literature, you're going to see these individuals who have their necks are burnt. They're not dead. They're not, and many times it's not, the flame does not go into the patient's lungs, but it will be like a, if you will, a skin burn type of deal. It's still a potentially avoidable, hazard or complication. Don't get trapped at the head of the bed without all the equipment and supplies that you need. Never remove the ET tube until the physician says so, typically done as the trach tube is inserted. Always confirm proper tube placement. No surprise there. Bronchoscopy assisting. So we actually do a pretty fair amount of this. We do a lot of it now with disposable devices. Generally involves using fiber optic equipment, examine the upper airway, vocal cords, tracheobronchial tree, etc. Go down, from actually as deep as the 6th division of the bronchi. It depends on the patient, but in general. Indications for performing the procedure may be diagnostic, therapeutic, or both. So diagnostic is you may be taking sputum samples directly, you may be taking brushings, you may be taking actual tissue samples themselves. The therapeutic part is they may have mucus plugs, the mucus itself. So often it's both. Equipment may involve flexible or rigid bronchoscope. For all intents and purposes, most of the ones that are done are flexible, whether it be disposable flexible or ones that are non-disposable, the Olympus setups are non-disposable. Indications, contraindications, indications, diagnostic to investigate lesions, hemoptysis, etc. Obtain lower airway secretions, cell wall washings, and tissue samples. Therapeutic, mucus plug removal, aid with difficult intubations, retrieve foreign bodies. I could talk a lot about them, but we retrieved different things out of patients. It's interesting. We actually went down and we saw there was a sheet metal worker who had aspirated a sheet metal screw. Didn't know it, thought he actually swallowed it and pooped it out the next day. Turned out he didn't swallow it. He aspirated it. He got like an abscess a couple months later. And the x-ray, you could kind of see, you could, look like it was a foreign body. They went down and we saw this screw, but by then the tissue had grown around it. And the physician saying, "You think I can get it?" And we're like, no. So he ended up actually, they ended up going down to the OR. They did a rigid. They were able to actually do minor surgery to actually remove the screw and excise any infected tissue and that sort of thing. But when the physician's like, "Do you think I can get it out?" I'm like, I was like, no, just say no. Contraindications: lack of informed consent, inability to adequately oxygenate and or ventilate the patient, coagulopathy or uncontrolled bleeding, unstable hemodynamic status. Yeah, so who might benefit? This particular X-ray is showing you, it really looks like a right lower lobe consolidation where you can actually see the costophrenic angle, but you see the kind of like a hilar opacity, and it really is looks pretty well consolidated in that lower lung field. So that may be like a series of mucus plugs that you may be able to get to and help restore ventilation to this portion of the lung. Our role prior to bronchoscopy: identify the potential need, review the chart, ensure the medical order, informed consent, and the other documentation that I referred to, checking for contraindications, including but not limited to things like clotting times. Prepare and test equipment, including bronchoscope, light source, basically meds, specimen traps, etc. Patient assessment, so education, pre-medication, patient prep, including a lot of different facets as well. During bronchoscopy, ensure proper functioning of all equipment, monitoring the patient and document the vital signs. Respond to adverse reactions. Bleeding, hypoxemia is most common. If they're taking tissue samples, they may be bleeding. The way you respond to that most commonly would be, sometimes they'll actually use ice water solution, but they can also use things like epinephrine that will actually shrink, the vasculature, so it'll cause vasoconstriction, reduce the bleeding. In some extreme cases, a tamponade balloon that will actually inflate and tamponade the site to basically apply direct pressure. Assist the physician obtaining specimens in medication administration. Ensure specimen vials are all properly labeled. Monitor and document as appropriate. RTs can't push meds, as we said earlier on, but RNs and physicians can. After bronchoscopy, monitor the patient's clinical status, respond as appropriate. Clean, sterilize, disinfect, and store the equipment. Ensure the specimens are sent to the lab. document results in the chart, and complete other records as appropriate. Take-home notes for bronchoscopy. Again, timeout is important, or doing the correct procedure on the correct patient, the correct location, of the patient. Plan for the worst hazards, so hypoxemia for oxygen, bronchospasm, bronchodilators, mucus plugging, so mucomist, and possibly normal saline or hypertonic. For bleeding, as I alluded to before, epinephrine and tamponade balloons can be helpful as well. Don't administer meds not within our scope of practice in most states, and ensure equipment is properly processed and stored. Last procedure we're going to go over is chest tube. So placement of a sterile tube ranging from 24 to 36 French into the pleural space to evacuate air, fluid, or blood from the pleura. Tube is generally inserted through, for a pneumo, either the fourth or fifth intercostal space at the anterior axillary line. Okay, so it's not the sternum, but if you kind of go in between the sternum and the armpit would be the anterior axillary line. And notice that for air, pneumothorax, so you have air escaping, outside the lung in the intrathoracic space. So it's higher up. So it's the fourth or fifth. For pleural drainage, it's lower down. It's often the seventh intercostal space, mid-clavicular line, connected to a drainage system which often has 3 chambers, and we'll talk more about those chambers, is a longer-term alternative to a needle thoracostomy in the case of a pneumo. So what paramedics may do at an accident scene where there's a strong index of suspicion for a pneumothorax, where the patient is deteriorating rapidly, there's decreased breath sounds on one side, there's maybe decreased chest expansion on one side, there's the patient has had a blunt force trauma to the chest or one side of the chest or whatever, is they may actually make the call to insert a needle in order to decompress it, okay, at the site. If it's that, it will almost invariably, there may be a rush of air and the patient will improve almost immediately. Okay, so it's one of those cases where you don't have perfect information. In the field, you don't necessarily have a chest X-ray, but you may have a lot of other indicators that suggest that if we don't try this, that we may lose the patient. But again, the longer term solution would be, a chest tube. That would really be something that even a patient getting a needle thoracostomy, they're probably going to get a chest tube as soon as they come into the ED. Again, who might benefit here? A little tough to see. Sometimes the X-rays that you see, you're looking at it and say, wow, that right lung looks pretty well expanded, type of deal. You don't really see a good costophrenic angle, okay? And what you don't see, or any sort of vascular markings, you don't see any lung markings, vascular markings, okay, on that right lung. The other thing that's a bit subtle, but if you look closely, you can see this, that the trachea is actually collapsing towards that side. It's actually, if you will, deflecting towards the affected side, okay? And what looks like, consolidation is actually the collapsed lung itself, okay? So it's a bit of a, it's like a lot of things. The more experience you get at interpreting chest X-rays, the better that you actually get at it. So it's one of these subtle changes that, this is a complete pneumothorax, on one side, because it could be very subtle ones. It's just a slight pneumothorax. It may be clinically insignificant. They may administer 100% oxygen. If it's a small pneumo, just to try to, because it'll, if you will, the density issue, it may facilitate absorption and the rectification of a small pneumo. Large pneumo needs, a chest tube, and if not a chest tube in the field, a needle thoracostomy. Indications, contraindications, indication pneumo, hemo, empyema, and then a chylothorax is lymphatic fluid. And then a pleurodedesis, a treatment for recurrent pleural effusion. Most common cause of a recurrent pleural effusion is cancer. Okay, is a patient has metastatic disease or just a primary cancer in the lung, and what they do is they'll actually put a chest tube in, and they will pleurodedese the patient, which they actually put a talc solution. You're not curing the patient, but you're reducing the chance that the fluid will reaccumulate. So contraindication, severe coagulopathy and an uncooperative patient. Our role, help diagnose the need, help gather and set up the equipment, monitor the patient. During and after, monitor the patient for adverse response, including bleeding, tube dislodgement, secondary pneumothorax, or even clamping where it shouldn't be clamped. Ensure proper equipment functioning and troubleshoot and document, as I've mentioned for the other procedures, documenting what you did, how well they tolerated it, if there's any charges or productivity issues there as well. And this may look like a little bit silly here, but it's showing the old system with bottles. It's really not silly at all, because this same depiction is so when you have like a Pleurovac, which is the drainage system that's still used today. Okay, it's based on the same principle as what's being shown here, the old-fashioned 3 bottles. Okay, so what you have on the right-hand side is that's actually going to the patient. What you have all the way on the left-hand side is the suction regulation. Okay, so the one that's closest to the patient would be the drainage collection. Okay, so you're getting air, but you're also often getting, if you will, pleural fluid. You may be getting some blood in that patient who may have a pneumo, but also has, if you will, a direct insult. The tissue is damaged in some way. It's releasing, fluid. So that the chamber closest to the patient is what's called, again, the drainage collection. The water seal in the middle, okay, is to keep the, if you will, the flow, if you will, if you keep the actual suction going in the appropriate direction, not going the other way. And the one that's closest to the wall of the suction is the actual suction control. So it's not the suction setting you set at the, if you will, suction regulator. It's actually the suction control itself. That chamber is what will determine how much suction is actually going to the patient. So some of the basic troubleshooting, and again, I know nurses do a lot more troubleshooting than we do, but just to kind of enhance your awareness. So if the suction control chamber does not bubble, adjust the suction pressure at the wall to, if you will, greater than negative 20 centimeters. Check the tubing. So, look at the suction regulator to the chamber for leaks or obstructions, and ensure that the atmospheric vent is not obstructed. Any one of these 3 things can actually affect, if you will, a suction control chamber that does not bubble but is supposed to. If the water seal chamber stops tidal movement, that's the middle one, check for an obstruction, a clot or a clog in the tubing and the device. And they're saying one of the recommendations is to milk it by compressing and releasing the tube from the patient towards the water seal chamber. So 2 basic ways that you can troubleshoot that. Continuous bubbling in the water seal chamber indicates the presence of a leak. Okay, so the question is it a leak in the system? Is it a leak in the patient? Okay, so at or in the patient or in the drainage system itself. To distinguish, which is it? Is it the patient? Is it something with the actual setup? To distinguish, briefly pinch the tube at the insertion point, okay, to the patient. If the bubbling stops, the leak is at the insertion point. Okay, tube is partially out, or there's some sort of a fistula. If the bubbling continues, look for loose connection. It's the equipment. Replace the drainage system, etc. Those are some basic maintenance issues. Take-home notes for chest tubes: ensure that the patient is pre-medicated. The tissue, in and around the lungs can be very, very well innervated. It can be very painful. The tube should be inserted above and not beneath the rib. So what you have is your ribs are sort of concave. Okay, the tops of them are convex, the bottom are concave. In that concaveness is basically is an artery, a vein, a nerve. Okay. If you, for some reason, don't ride on top of the rib, and in some way, put it in the bottom portion there, you could impede or in some way injure the vessels, the vein, the artery, or the nerve. So it needs to be right on top of the rib. Once inserted, the tube should be secured, usually with a couple of stitches that the doctor will do. Volume may be lost if the patient's on a vent, so just keep that in mind. If you have active, if it's running to suction, which many times it is that you'll be giving the patient 500 mLs and you'll be losing, you'll be getting 400 back. So you'd be losing 100, 125, whatever. So just kind of keep that in mind as well. Recommend a post-procedure chest x-ray like we did with several of our other procedures as well. Selected references, Irwin has a real good one. Again, I put a plug in here for Egan's Fundamentals, as well as some others as well. I want to thank you guys for attending today. Hopefully, again, you got something out of this presentation, and we really hope that you come back to us. Thanks a lot and have a wonderful day.